So I'll be speaking about screening for retinopathy of prematurity, a competency-based training program. Just think of the statistics. ROP screening, something which is done by general ophthalmologists, but no, more than that, mainly by retina and the VR people. About 20,000 ophthalmologists in India, just a few hundreds, maybe about 200, vague range, are the ones who are VR surgeons and actually doing VR screening. 3.5 million babies, premature, born each year. We definitely have a gap where we need to train more people to screen for ROP. Traditional ophthalmology residency training does not train people because of limited exposure to this particular thing of ROP screening. Let's talk about competency-based training. This training, as contrary to the traditional one, emerges from health need, that's our need to have more people. It defines its outcome or competency based on what we require, train people, defines its curriculum along that, and we devise the teaching, learning, and assessment strategies based on exactly what we need. What does that mean? Let's train them in all the domains, not just in knowledge. Knowledge, of course, the skills of patient care, the skills of procedural skills, the attitude or communication, that's professionalism and communication. When we talk CBME, we say we define objectives. These are the specific objectives. And there is year-wise progressive outcome. We focus on what a learner should know. And it provides clear specific goal for what the teacher, the student, as well as the assessor or the examiner or the nation as a whole needs to know what is our training. Year 1 is a foundational skill training. What's the outcome? Observe and assisting a newborn ocular screening. Note, I did not use the word preterm, just a newborn ocular screening. We talk in different domains of what we are going to teach, starting from basics of the knowledge, patient care, professionalism, and there is one extra word added, the teamwork. So here the students just learn to work in interprofessional team. Learn to work with optometrists, learn to work with pediatrician, learn to work with nurses around. Second year is of supervised clinical practice where they'll be able to do independent newborn ocular screening and supervised ROP screening without speculum. We increase the level of each of the domains what we are talking, whether it's knowledge, the skill, or the professional and communication. Now look at another important part, the teamwork. That's interprofessional working. Earlier they were just part of a team, now they are working in a team. Huge difference. I can be part of a group but not work with them. As they grow older in their training, they start working with the team. The final year is when they learn about entrustment and independent performance. What's the outcome? Independent ROP screening with speculum and camera imaging. Now here, as a team leader, as a part of the team, as they become senior, they learn to manage interprofessional. Look at how the knowledge changes. Now they'll be able to observe and actually stage and classify ROP. They'll be actually able to try and use speculum, staging, identifying various things, working in a team together. What are the strategies we use to teach? Interactive lectures, supervised clinical practices, role play, simulation, peer-assisted learning, reflective portfolios or e-portfolios. Assessment plan, what's the major? So many things here. It's different for each year. Why is it different? Because we taught different things. As we increase in the year, our assessment changes from simple question answer or MCQ to OSCE to DOPS. Where towards the end, we even ask them to reflect. We take a 360-degree feedback. Initial year, the feedback is just from the sisters, mainly, because that's whom they work with more. As they grow older, the feedback comes from their juniors, how they're managing the sisters, everybody who's around them. What is it that we expect? The expected outcome. We expect through this competency-based program to develop a skilled ROP screening team, where our expected outcome would be improved neonatal eye examination, care skills even in a resource-limited settings. So here, the basic ophthalmologist gets trained in not just screening a baby, any neonate, a preterm baby, and also in a medical college or a eye care setting. So every facility is not available there. That's what we would emphasize on. Very, very important, enhanced empathetic communication skills with parents with vulnerable population. Remember children who are in NICU. So they learn the skills how to communicate with them. And of course, the most important, improved teamwork skill. This is what we would expect when we train in a competency-based system. What's important for us to understand, when I talk of future direction and scalability, what am I thinking? we are just using this as a model for training ROP. The same model, the same way can be upskilled, scaffolded on training other components of our branches. So when I say 3 years, you might wonder, ROP for 3 years? No, it's not just ROP screening. It's multiple things which we scaffold, which we teach in a structured pattern. So this is what is a stage-wise, outcome-based or a competency-based program for anything. Here we focus on ROP screening. So what's our aim here? Let's build, sorry for the typo, skilled interprofessional ROP screening teams so that no baby goes blind because we were not there to screen them. Thank you so much for your patient hearing.